Welcome to the deep dive. Today, we're really getting into the nuts and bolts of how our bodies run. The topic, problems related to regulatory and reproductive mechanisms.
That's right. We're pulling insights straight from Lewis's Medical Surgical Nursing, the 12th edition.
And our mission isn't just to skim the surface. We want to dig deep, connect the dots between these, sometimes complicated chapters, and give you a really clear, practical summary, especially for you nursing students listening in.
Exactly. We want you to see the bigger picture, how conditions that might seem separate are actually deeply connected.
So how does this all fit together when you're actually on the unit?
It all comes down to balance. This whole section is about the body's control systems, the endocrine hormones, reproductive hormones. They're constantly talking to each other. And when that communication, that balance gets disrupted, it's like a domino effect. Problems pop up everywhere. Understanding why that happens, those core mechanisms, that's the key to really good patient care.
Right. Because often what walks in is just someone saying, I don't feel right, vague stuff.
Totally. And our job, your job as nurses, is to be the detective, to spot the patterns hiding in those vague complaints.
Okay, let's unpack this then. Where do we start?
Let's start with the basics. Hormones, the endocrine system's messengers.
Okay.
These are chemical signals sent out by endocrine glands. They travel through the blood looking for their specific target cells.
Like a lock and key, right. I remember that from the text, figure 52.2.
Exactly like a lock and key. Thyroxine from the thyroid, for example, doesn't just hit one target. It affects metabolism in almost all body tissues. It's got keys for lots of locks.
Gotcha.
And the regulation is, honestly, brilliant. It's mostly negative feedback. Think calcium and parathyroid hormone, PTH.
Yeah.
Calcium levels drop low. The parathyroid glands release PTH.
Okay.
PTH tells bones to release calcium, kidneys to save it, gut to absorb it. Calcium levels rise.
And that shuts off the PTH release.
Precisely. It's self-correcting.
Yeah.
Plus, the nervous system gets involved, and there's these cool physiological rhythms like certain hormones peaking during sleep. The menstrual cycle is another rhythm, but longer, infradian.
So these messengers do a lot. We mentioned thyroxine. What about others?
Adrenal medulla, that's your epinephrine, norepinephrine, fast stress response, fight or flight.
Right.
Then the adrenal cortex corticosteroids. Think inflammation, electrolytes, even some sex hormones, vital stuff.
And the pancreas, insulin.
Huge role. Insulin lets glucose into cells. Glucagon does the opposite, raises glucose. Pancreas is central to metabolism.
Okay. And the gonads, ovaries, testes.
Estrogen, progesterone, testosterone, secondary sex characteristics, reproduction, bone health too, all hormonally driven.
So with all these systems interacting, I imagine problems can be sneaky.
Very sneaky. That's the challenge. Endocrine issues often start gradually. Vague symptoms, fatigue, weight changes, maybe skin issues, stuff easily blamed on, life.
Like stress or getting older.
Exactly. But these could be red flags for a deeper endocrine problem. That's where sharp nursing assessment comes in. You got to connect the dots.
Okay, let's talk assessment then. Our patient, LM, 35 years old, comes in, just not feeling well. Tired, gained weight, irritable. How do we start digging?
We start broad with a really thorough health history. Your pattern hunting, any family history, diabetes, thyroid issues, endocrine cancers. That's huge.
And genetic link.
Then nutritional metabolic, appetite changes, weight gain or loss that they can't explain, nausea, feeling unusually hot or cold.
LM's got weight gain and fatigue.
Okay, so explore that. Activity levels, sleep patterns. How's their energy, really? Any changes in memory or thinking that could point to thyroid or electrolyte issues.
And don't forget how she feels about herself, right? Self-perception.
Critically important. If she's gained weight or has skin changes, how does that impact your self-esteem? It's all part of the picture.
Then the physical exam. Vitals, obviously. Height, weight, BMI.
Absolutely. And then look closely at the skin and hair. Is there hyperpigmentation, that bronzing maybe on the knuckles, that screams Addison's? Or decreased pigment, hair loss, excess hair growth, dull hair, all clues.
LM had that reddened, puffy face and the lump on her neck shoulders. And acne, hair on her lip.
Okay, classic signs potentially pointing towards Cushing's. That lump could be the buffalo hump. We'd also check the thyroid, though a normal one might not be palpable. Abdomen, any stray. Purple ones. Truncal obesity.
Yeah, she had purple stretch marks and the protruding abdomen with thin arms and legs.
Textbook Cushing's presentation. In extremities, check for large hand feet like an acromegaly or signs of low calcium like Trousseau's sign.
Okay, let's put on our NCLEX hats. LM's findings. Weight gain, fatigue, puffy face, buffalo hump, acne, hirsutism, truncal obesity, thin limbs, edema, bruises, purple stereo. What worries you most, and what are your priority questions for her and maybe her husband?
Wow, yeah. That cluster of symptoms, the truncal obesity, thin extremities, moon face, buffalo hump, pupil striae, easy bruising, it's highly suggestive of Cushing syndrome, hypercortisolism.
Right.
My absolute priority questions would be at the onset and progression. Ellen, when did you first notice these changes? Have they been getting worse gradually, or did they come on suddenly? Tell me about your energy levels day to day. I need to understand the timeline. I'd also ask about medication history, specifically any steroid use, and maybe ask her husband if he's noticed changes over time too.
Good point, involving the family. And diagnostics. What tests confirm this?
For suspected Cushing's, we'd look at cortisol levels, maybe a 24-hour urine cortisol or late-night salivary cortisol. A dexamethasone suppression test is key. Blood glucose and electrolytes are important too. Imaging like a CT or MRI of the pituitary or adrenals might be needed to find a potential tumor.
And our job as nurses during testing.
Crucial. Ensuring the patient understands the prep, like fasting if needed. Timing blood draws correctly, especially for cortisol with its daily rhythm. Minimizing stress before the test. Documenting everything accurately.
Okay, so we know how to assess. Let's connect findings to diagnoses. Starting with a big one. Diabetes mellitus, Chapter 53 in Lewis's.
Ah, yes, DM. You'll see this constantly. First hurdle, knowing type 1 versus type 2. Okay. Type 1, usually abrupt onset, autoimmune. The body attacks its own insulin-producing cells, so little to no insulin is made.
Requires insulin therapy from the get-go.
Exactly. Type 2, more gradual. It starts with insulin resistance. The body's cells don't use insulin well. The pancreas tries to compensate, makes more insulin, but eventually it can't keep up. Often linked to lifestyle factors, obesity, metabolic syndrome.
You mentioned metabolic syndrome, that cluster of risks, right? High glucose, belly fat, high BP, cholesterol issues.
That's the one. Big precursor to type 2.
And for management, those ABCs are key: A1C, blood pressure, cholesterol. But you said only about 1 in 5 adults meet all 3 goals. That's sobering.
It really is. Shows how tough long-term management can be. Drug therapy is a cornerstone. For type 1, it's all about insulin. Usually a basal bolus plan.
Mimicking the body's natural rhythm.
Trying to, yeah. Long-acting basal insulin once or twice a day, plus rapid-acting insulin like Lispro or Aspart before meals. Timing is everything within 15 minutes of eating for the rapid-acting.
And injection sites matter, rotating them.
Absolutely critical. Prevents lipodystrophy. Insulin pumps are another option, continuous infusion. For type 2, we often start with oral meds. Metformin is usually first line.
What's the mechanism there?
It mainly decreases glucose production by the liver and makes the body more sensitive to the insulin it does produce. But remember that huge drug alert.
Right. Stop metformin before avi-contrast die. Risk of kidney damage.
Exactly. Other orals include things like DPP-4 inhibitors or GLP-1 agonists, which work in different ways to help control glucose.
And nutrition's huge, too. Carb counting.
Essential skill for patients, usually focusing on servings of 15 grams of carbs. And exercise. Check glucose before, maybe during after. If it's 100 or less beforehand, have that 15G carb snack.
What about when patients get sick, like with the flu?
Rules change slightly. Got to check glucose more often, maybe every 4 hours. If type 1 and glucose is over 240, check for ketones. Need to stay hydrated and keep taking insulin? Maybe even need more. Contact the doc if glucose stays really high or ketones are moderate high.
That leads us to acute complications, DKA.
Diabetes-related ketoacidosis, mostly type 1. Profound lack of insulin leads to super high glucose, breakdown of fat for energy, which produces ketones, causing acidosis and massive dehydration. It's a true emergency.
And HHS?
Hyperosmolar hyperglycemia syndrome, more common in type 2. They have some insulin, so usually no ketones, but glucose goes incredibly high, leading to severe dehydration and electrolyte imbalances. Also an emergency.
Management for DKA. You mentioned fluids first.
Absolutely. 4V fluids are priority number 1, usually normal saline initially.
Yeah.
Then an IV insulin drip, regular insulin, careful monitoring of electrolytes, especially potassium, is critical. And you add dextrose to the fluids once glucose drops to around 250 to prevent dropping it too fast and causing cerebral edema.
Okay. And the opposite problem, hypoglycemia, glucose less than 70.
Yeah, too much insulin or not enough food causes shakiness, sweating, palpitations. That's the adrenaline kicking in. If it gets worse, confusion, vision changes, even coma, neuroglycopenia.
Treatment.
If conscious, the rule of 15, give 15 grams of fast-acting carbs, juice, regular soda, glucose tabs. Wait 15 minutes. Recheck glucose. Repeat if needed. If unconscious, no liquids. Glucagon injection or IV dextrose.
So important to teach patients and families how to handle lows. And then there are the long-term complications.
Ugh, yes. primarily prevented by tight glucose control over years.
Hmm.
Microvascular,
Yeah.
retinopathy, eyes, nephropathy, kidneys, neuropathy, nerves.
That stocking glove neuropathy. Loss of sensation in the feet is so dangerous.
It is. That's why daily foot checks and monofilament testing are vital. Then there's autonomic neuropathy affecting gut, bladder, heart function, and macrovascular. Increases risk of heart attack, stroke, peripheral artery disease.
So blood pressure and cholesterol control are just as important as glucose control.
Absolutely. It's a package deal.
This really underscores the need for patient education. What are the absolute must-teach points?
How to monitor glucose accurately. Medication adherence, taking it as prescribed, understanding how it works, sick day rules, hypoglycemia awareness and treatment, proper foot care, carrying medical ID, planning for travel. It's ongoing reinforcement.
Okay, let's pivot slightly. Thinking about other endocrine glands, pituitary, thyroid, adrenals, can we frame their issue simply as too much hormone or too little?
That's a great framework. It covers most of the major problems. Take the pituitary, the master gland.
Right.
Too much growth hormone after puberty. Acromegaly, overgrowth of hands, feet, face, usually from a pituitary tumor. Too little of various pituitary hormones. Hypopituitarism. Deficiencies in ACTH or TSH are life-threatening.
And surgery on the pituitary, like hypophysectomy, what are the risks?
Big ones are CSF leaks, so no nose blowing, watch for clear drainage. Also risk of diabetes insipidus or SIADH because ADH regulation can get disrupted. Hematoma, risk pressing on the optic nerve too.
Okay, ADH. Too much ADH gives you SIADH.
Correct. Syndrome of inappropriate ADH. You hold on to too much water, get dilutional hyponatremia. Fluid restriction is key.
And too little ADH.
Diabetes insipidus, or DI. Totally different from DM. Here, you pee out massive amounts of dilute urine, leading to dehydration and hypernatremia. Need lots of fluid replacement, maybe synthetic ADH.
Got it. Now, thyroid. Too much thyroid hormone.
Hyperthyroidism, like Graves' disease. Everything speeds up. Fast heart rate, weight loss, heat intolerance, maybe those bulging eyes, exophthalmos.
Treatment.
Antithyroid drugs, radioactive iodine therapy, which can eventually cause hypothyroidism, or surgery, thyroidectomy.
And post-thyroidectomy. Watch out for.
Airway. Swelling can compress the trachea, bleeding, damage to laryngeal nerves causing hoarseness, and accidentally removing the parathyroids leading to hypocalcemia. Check for Fostex and Trousseau's signs. Keep IV calcium gluconate handy.
Okay. And too little thyroid hormone.
Hypothyroidism. Everything slows down. Fatigue, weight gain, cold intolerance, constipation. Treatment is lifelong levothyroxine.
And that drug alert for levothyroxine.
Yes, especially in patients with heart disease. Start low, go slow. Monitor heart rate. Report pulse over 100 or any chest pain immediately. Take it in the morning on an empty stomach.
Right. What about the parathyroids themselves? Too much PTH.
Hyperparathyroidism. Leads to high calcium to low phosphorus. Think bones, stones, abdominal groans, and psychic moans. Fatigue, muscle weakness, kidney stones, bone pain. Surgery is the main treatment.
Okay, adrenals again. Too much cortisol. We talked about Cushing's.
Yep, Cushing syndrome.
Uh-huh.
Truncal obesity, moon face, buffalo hump, purple striae, high blood sugar, high BP, risk for infection, often caused by pituitary tumor or long-term steroid use.
And too little cortisol and aldosterone.
Addison's disease, adrenal insufficiency, fatigue, weight loss, that bronze skin, low blood pressure, low sodium, high potassium, low glucose. It's life-threatening if untreated.
And the key teaching for Addison's.
Lifelong hormone replacement. And critically, stress dosing. They need more steroid coverage during illness, surgery, major stress. Must carry an emergency kit with injectable hydrocortisone and wear a medic alert bracelet.
Got it. And pheochromocytoma. That's the adrenal medulla tumor.
Right. Spits out excess catecholamines, epinephrine, norepinephrine, classic triad. Severe pounding headache, tachycardia, profuse sweating, dangerously high blood pressure during attacks.
And a big nursing alert.
Do not palpate the abdomen.
Can trigger a massive catecholamine release. Diagnosis is often via 24-hour urine for metanephrines. Treatment is surgical removal.
Okay, that covers a lot of regulation. Now let's shift to the reproductive systems, still heavily influenced by hormones.
Right.
Absolutely. The hypothalamic pituitary gonadal axis. GnRH from the hypothalamus tells the pituitary to release FSH and LH, which then act on the ovaries or test to produce estrogen, progesterone, or testosterone. It's another intricate feedback loop.
And changes happen with age, like menopause in women.
Definitely. Decreased estrogen leads to symptoms like hot flashes, vaginal dryness, and increases long-term risk for heart disease and osteoporosis.
What are some common female reproductive issues nurses encounter? Chapter 58 covers a lot.
Big ones include infertility, evaluating both partners is key. Issues around pregnancy like spontaneous abortion or ectopic pregnancy require sensitive nursing care, including psychosocial support and ROGM if needed. Premenstrual disorders like PMS, PMDD, abnormal uterine bleeding needs careful investigation.
What about PCOS?
Polycystic ovary syndrome, very common. It's a hormonal imbalance leading to irregular periods, signs of high androgens like hirsutism or acne, and often insulin resistance. Major cause of infertility, too.
And infections.
Things like yeast infections, bacteriovaginosis are common.
Hmm.
PID, pelvic inflammatory disease, is more serious an infection ascending into the uterus, tubes, ovaries, often from STIs.
Yeah.
Can cause infertility or chronic pain, requires prompt treatment and partner treatment.
Then there are benign issues like fibroids, endometriosis, pelvic organ prolapse, and gynecologic cancers.
Right. For cancers, cervical cancer is the one with good screening PAP and HPV tests. Ovarian cancer is often diagnosed late, unfortunately. Nursing role is huge in prevention, HPV vaccine, and risk factor education.
And a really sensitive topic, sexual assault.
Yes. Defined as any sexual violence without consent. Our role as nurses is critical. Provide immediate compassionate care, offer emotional support, perform a forensic exam if the patient consents, provide STI pregnancy prophylaxis, and make appropriate referrals. Non-judgmental care is paramount.
Okay, shifting to male reproductive health, Chapter 59. Similar hormonal control.
Similar axis, yeah. GnRH, FSH, LH, leading to testosterone production in the testes. Testosterone levels naturally decline with age.
What's a major issue we see in older men?
Yeah.
BPH.
Benign prostatic hyperplasia. Very common. Enlarged prostate squeezes the urethra, causing urinary problems, urgency, frequency, weak stream, nocturia.
How's it treated?
Medications first. Often. Alpha blockers relax the muscle. 5-alpha reductase inhibitors shrink the prostate. If meds aren't enough, minimally invasive procedures or surgery like TURP, transurethral resection of the prostate.
And post-TURP nursing care involves?
Managing that continuous bladder irrigation to prevent clots, monitoring for bleeding, managing bladder spasms, watching for infection, and teaching about potential incontinence and Kegel exercises.
What about prostate cancer?
Often slow-growing, androgen-dependent. Risk factors: age, Black ethnicity, family history. Screening involves PSA blood test and DRE, but it's a shared decision-making process with the patient about whether to screen.
Treatments vary.
Widely. From active surveillance for low-risk cancers to radical prostatectomy, often robotic now,
Yeah.
radiation, hormone therapy, sometimes chemo for advanced disease.
And ED, erectile dysfunction.
Can have many causes: diabetes, hypertension, post-prostatectomy nerve damage, psychological factors. Treatments include oral meds like sildenafil Viagra or tadalafil Cialis.
And the big warning with those.
Absolutely contraindicated with nitrates. It can cause life-threatening hypotension. Other options exist too. Vacuum devices, injections, implants, counseling.
Okay, last major section, but super important as it links everything. Sexually transmitted infections, STIs, Chapter 57.
Critical topic. Affects everyone. Prevention is job one. Abstinence, mutual monogamy, reducing risky behaviors, and correct and consistent condom use. We also talk about pre-IP for HIV prevention now.
What are some common STIs nurses need to know?
Chlamydia and gonorrhea are bacterial, super common, often asymptomatic, especially in women. Can lead to PID, infertility if untreated. Easily diagnosed with NAT tests and treated with antibiotics, often treat for both together. Remember doxycycline precautions? Empty stomach, no dairy antacids, sun sensitivity. Trichomoniasis is parasitic, also common. Then you have STIs causing lesions, genital herpes, HSV1 or 2. Lifelong virus causes painful outbreaks, but manageable with antivirals. Big psychosocial impact. HPV, human papillomavirus, causes genital warts and is linked to several cancers. The HPV vaccine is amazing prevention.
And syphilis.
Bacterial. Progresses in stages if not treated. Starts with a painless chancre, then a rash, often palm soles, then can become latent or progress to tertiary syphilis affecting organs. Diagnosed with blood tests, treated effectively with penicillin.
With all STIs, the diagnosis can be emotionally tough for patients. How do we support them?
Huge part of our role. Provide a safe, non-judgmental space. Acknowledge feelings of embarrassment, shame, guilt. Encourage them to talk. Stress the importance of finishing all medication, even if they feel better. And critically, partner notification and treatment essential to stop the spread.
Plus, reinforcing safer sex practices for the future.
Always. Education is power. We need to address casual attitudes and highlight the serious potential long-term consequences like infertility or chronic pain.
Wow. We've covered a massive amount of ground, from hormones acting like tiny keys to the complexities of diabetes management, reproductive health challenges, and STIs. It really drives home how interconnected these regulatory and reproductive systems are.
Absolutely. They don't exist in silos.
Mm.
Understanding that interplay, seeing the patterns, that's what elevates nursing care from just tasks to truly holistic assessment and intervention.
It really emphasizes the nurse's role as that detective, that pattern spotter, using critical thinking and collaborating with the whole team.
Exactly. You're the guide for the patient, navigating these often confusing and sometimes scary health issues. Empowering them with knowledge is one of the most important things we do.
Well, hopefully this deep dive has sparked some connections and maybe a few aha moments for everyone listening. Thank you so much for joining us today.
Yeah, thanks for diving in with us.
And a big thank you from the whole Last Minute Lecture team. We appreciate you making us part of your learning. Now, as you go forward, here's something to think about. How might really internalizing this idea of delicate balance within these regulatory and reproductive systems change how you advocate for your patients, how you promote health, even in situations that seem totally unrelated at first glance? Something to mull over.